Hi, I'm Sam Bennett. I'm Head of Integrated Personal Commissioning and Personal Health Budgets at NHS England, responsible for both the policy and strategy development and the delivery programme for personal health budgets and its expansion across all CCGs in England, and also heading up the Integrated Personal Commissioning programme and supporting the 9 demonstrator sites over the next 3 years. We've focused IPC on those people that get the worst experience of health and care at the moment by virtue of the complexity of their needs and the number of different services that they need to engage with to be able to live a good life. So we've focused on people with learning disabilities, particularly those with behaviour that challenges traditional services, with people with severe and enduring mental health problems, older people with multiple long-term conditions, and importantly also this is an adults and children's agenda, so we're focusing on children with complex needs as well. The overall purpose of the programme is to improve their quality of life, to better integrate health and social care services and education where that's appropriate around the needs of the individual, and to improve their experience of care and reduce unplanned hospital admissions and inappropriate placements in institutional settings where that's avoidable. We would describe 5 key shifts that are central to what we're trying to deliver through IPC. The first of those is that it's a targeted approach that improves people's experience of care and prevents crises where that's possible. It is a targeted approach. Sites have identified specific cohorts of people that they think would benefit from a very different, very bespoke, very personalised experience of care, and are approaching those people with a clear offer of a different conversation. That's the second shift that we want to see, is a very different conversation for people with the clinicians and other professionals involved in their care, which is less about fixing them or looking at just medical needs, and more about how we develop a holistic plan for people's health and well-being needs that responds to what's important to them as well as what's important for them. A big part of that, and the third shift, is a real strong community and peer focus through that planning conversation. So we're not assuming that statutory services are the answer. We're working proactively to link people into community-based resources and to strengthen their connections to their community. And we're putting them in touch with peers who have lived experience that can help strengthen their capacity to self-manage. This is about building people's skills, knowledge and confidence to be able to manage their condition better with the support of the services that they need. The fourth key shift is to enable people and their families to take direct control over the resources available for their care. This is the bit that's about extending personal budgets, both personal budgets that are funded through the NHS, through social care, and integrated personal budgets where people's needs require funding from different sources. So one of the offers that we made through the planning conversation is for all or part of the money that's available to support someone to live a good life to be taken as a personal budget. And the final shift is we would want people to be able to have a wider range of options for how they use that resource that is truly tailored to their needs and preferences. So rather than just linking people into a generic set of service options, we're looking to design services around people's individual needs and requirements and develop a broader range of service options that people can choose from in that. IPC is one of a range of different integration programs happening across the NHS and social care at the moment. It's the only one, however, that really focuses in on how we integrate health and care around the individual at a level where services are able to respond to their particular needs and preferences. And the budgetary integration we'd see through IPC is about blending resources from across health, social care and other areas, education where that's appropriate, at an individual level through personal budgets. So wider integration programs have tended to focus at system level or at macro sort of budgetary integration, and this is very much taking that down to the individual level and designing care from the bottom up around their individual needs and preferences.
I'm James Sanderson. I'm the Director of Personalisation and Choice at NHS England. We're providing support through regional representatives assigned to each site that are able to provide knowledge and experience. We have a number of specialists who are able to unlock key components of IPC, such as information and governance, such as finance, such as person-centred planning. I want to see that personalisation and choice become default settings within the health service. There's a lot of work to do in that area. but there's a lot of exciting possibilities as well that brings. There needs to be a shift from a paternalistic healthcare system to one that actually involves the patient at the centre and enables the individual to structure care around their needs, because there's proven evidence that can greatly assist the achievement of better health outcomes. There's multiple factors involved in making IPC and personal health budgets a success. The key factor, I think, is really an active partnership. All of the providers have got to work together. CCGs, providers, local authorities, NHS England and the voluntary sector and people themselves. This needs to also have an element of co-production. Peer leadership is incredibly important here. And if we bring all partners together, as we have done in the recent IPC residential, it enables us to use the strength of those numbers and the influence that those people have in order to create a really, really healthy and productive programme.